what I'm going to offer you today is a description of 2 panels of tests that you can do now. They're easily organized, they're readily available, you do need a practitioner, and they will tell you the first panel it's an American test, but it's very easy to get the samples there, serum only, and urine, which will tell you up to arguably 14 years before you get cancer that you're at the beginning of a cancer process. Cancer is not a tumor. The medical profession likes to think of cancer as a tumor. Have tumor, have cancer. No tumor, no cancer. Get rid of tumor, you're in remission. It's not that simple. You don't one day suddenly have a whole tumor. You start off with cells. Cancer is not a genetic disease. It's an environmental disease that triggers off cellular changes at the electron transport chain within the mitochondria, within the cells. Forberg knew this in 1933 and said, we know now the ultimate cause of cancer is lack of oxygen to the cells and mitochondrial failure. Epigenetic, outside your body factors, trigger these changes. So secondary causes of cancer are all the things you've ever done wrong in your life or have ever been done wrong to you in your life, environmentally, food, drugs, and you all know about those. The third trigger is when these mitochondrial cellular changes turn into genetic changes that then stimulate cancer. And as long as we go looking for correcting the genetic problems, we're up at the third tier, and we're not getting to the bottom of it. So I propose to you that cancer is a process. It's a cellular process biochemically, and therefore, if we can detect that at the very beginning, that changed. Is that all right? Yeah. We still don't have the... All right. If we can detect these changes really early, you can get a head start. Now, in fact, it's argued, and there is evidence for, the fact that you can pick up changes up to 14 years, even 16, one study, before you start developing a tumor. One of the things in the first test panel, PHI, it's an alphabet soup, but PHI, can change and start rising in some studies up to 14 to 16 years before you start getting a tumor. HCG, a hormone, which we'll discuss in a minute, can be detected, and it should only be there in pregnancy or in cancer. In cancer, it's there way below the level it's in pregnancy, so the pregnancy test is quite useless. You need a super sensitive test for it. But it can start and then sit there. So you can still find out. The earliest test panel that was done some decades ago showed positive for all the people with cancer and positive for half the people without cancer. But those half people without cancer then develop cancer within the next 10 years. So that's the first panel. And if you get nothing out of this, you can use this panel of tests, which I will be around for the rest of, well, till tomorrow lunchtime anyway. I can ask you, but the last slide that I'll put up has the names of the 2 laboratories that do most of the tests. You can do this test to detect the beginning. You can use it closer to the, you may think, well, hey, I've got cancer, I don't know, or the doctor thinks I might have. You can do the test. You can do the first panel of tests when the doctors say, if you've had surgery, we got it all. But did you get it all? If the test shows you're clear, you don't need to think about going into the next phase of treatment they want you to. You can feel much more comfortable about reneging or refusing something you don't want, whatever it is. If you do the test a few months after you've had some sort of treatment and the results are still bad, you know they haven't got it all and you've got more work to do. And you can use the test, a few years later to make sure you're still in remission. And it gives you a solid basis of what you're doing. I'm not sure how to move these slides on. I may have to talk up from the... Does anybody know? Robin, thank you. You press one of these. Right. Oh, thanks, Robin. I've already covered that. Early detection is vital, of course. Now, I've had many people, when I've talked about this, say, oh, well, I wouldn't want to do the test. I really don't want to know. Head in the sand. But that's when they think of the treatment as being something they simply don't want to consider. When you can explain to them that the treatment is entirely modifying lifestyle, modifying diet, doing all the things that many of you are probably already doing, and once you start doing them, why stop? I have always done everything I've told every patient to do. No doctor can say that. So when I started and was working with Candida, I went on the Candida diet. When I was working with allergies, I put myself on diets without wheat or without milk or whatever. A decade or more ago, when I started working only with helping people with our current topic, I put myself completely on that program for long enough to know what it's like, how you have to manage, and a completely sugar-free, grain-free, processed fat-free diet, for instance, with all the other subtleties, long enough to know that you crave biscuits, so I developed a recipe book with nut biscuits and all sorts of things in it. And so I know what it's like to go through. And once you start, you think, well, hey, why the hell stop? Because it's good, it feels good, it's perfectly workable in most situations. Cancer, this is an interesting thought. Cancer is a systemic problem. We've had that said or mentioned yesterday. You don't get breast cancer because your breast's not producing breast milk. You don't get bone cancer because your bones won't let you walk, or kidney cancer because your kidneys aren't filtering properly. Cancer is a disease situated in a location, not of a location. And therefore, we are still back, however many, I mean, there's 200 types of cancer, and then somebody said, I think yesterday, there were 200 types of breast cancer now. I mean, it's just dividing the minutiae. It was up there. Yes. Okay. Yeah. I think that's essentially what I said. There is one thing called cancer. It's one systemic problem, and it's going to manifest wherever it manifests. It's even thought that if you've got breast-like cells in your cancer cells in your bones, that they are not fully developed breast cells that have become cancer cells. They are stem cells that started becoming breast cells and then failed and therefore became cancer cells. So they have some characteristic of the breast cells, but they're not breast cells. For our purposes, and this also applies not only to solid tumors, these tests apply to blood tumors and others as well. Thank you. We've got quite a bit of a way through here, I think. Right. And I'll touch now, I'm giving you the payoff story at the end first, because I know the rest of it's going to get a little bit technical, maybe for some of you. In fact, the people that read the thesis had to work hard to understand it. The second panel of tests is not done, I mean, these are two panels I've put together. The American crowd do most of the tests in their panel. There's a laboratory in Bournemouth that does a lot of the tests that, from which I've picked the ones that I think are really important. The second panel is much more useful if you know you've got cancer. It looks at characteristics of your individual cancer cells. Cancer cells have the ability to produce compounds that will increase the blood vessel supply so they can get blood to the tumors. If we analyze for a thing called VEGF and it's high, then we know your cancer is producing too much blood capillary growth. We have things that will stop that. And we know that they'll stop that because if at the same time you've got a cut on your skin, that cut doesn't heal because it's not getting new blood vessels. So in an extreme case, we know it works. You need to, we look for a thing called protein P53, which is your major defense against cancer. We look at levels of P21, which helps P53. Cancer cells resist suicide, the process called apoptosis. A blood compound called BAX, B-A-X, stimulates apoptosis. If your level is down, then we need to lift it up. BCL2 and a lot of compounds in that family are anti-apoptotic. They block apoptosis, so the cancer cells can thrive. If you've got too much of that, you need something that will bring that level down. Survivin gene produces a compound that protects the cancer cells, helps them not to die. If your survivin level is up, you had better fix that even before you spend a lot of money on all the other things you can do, like pancreatic enzymes for breaking down. I've had patients who have got rid of their high survivin before they've done anything, and then the practice, it's worked like a charm. Tumors do all those things, but one thing that makes a benign tumor malignant is metastases. So we look at some protein enzymes called MMP2s that are a measure or an indication of how easy it is for cancer cells to invade the tissues. It's very hard for a cancer cell to break out of a tumor. It's got to break out of the tumor, through a blood vessel wall, dodge all your immune factors, break out of the blood vessel wall, force its way into a tissue. Very hard to do. It's not just like a piece falls off and wanders around and latches on and that's done. So this is why biopsies can be a problem, because you've bypassed all those difficulties for the cancer cell. So if your MMP2 level's high, we have to strengthen your connective tissues. That, in a nutshell, is what I want to tell you this morning. So we can all now go and have cheesecake across the road with no sugar in it. I need to just go back to where I'll do the first bit off my top of my head. Dr. Beard said at the beginning of the 1905 time, cancer and placenta are identical. Not the same or similar, identical. For all you women who've had babies, you've had cancerous activity while this little morula of embryo has, it's jolly hard for half a dozen or 16 little cells to get to the uterus and not just get swept out. Just as it's hard for a cancer cell to get an invasion block. It does exactly what cancer cell does. It produces HCG, which facilitates the whole process. And placental cells, cancer cells do the same thing. It stimulates progesterone, it gets the uterus working and all that sort of thing. It stimulates and helps the MMP proteins that encourage the invasion. And if that whole process continued indefinitely, you get choriocarcinoma, pregnancy cancer, and you and the baby die. But on the 55th day of the pregnancy, more or less, just about 2 months in, the fetus's embryo, the fetus's pancreas starts to work. Now this is mad. The pancreas deals with digestion, mum's doing that. The pancreas deals with blood sugar level, mum's doing that. What the pancreas also does is produce pancreatic enzymes, and these stop the HCG-related activity of invasion and so on and so forth, which is why you'll get so many people suggesting pancreatic enzymes are useful. In restoring homeostasis, that's all we're allowed to say you can do, but it works. And this is why HCG is part of the test. The next part of the test is a thing called PHI. For those of you who understand the cells, glucose is of all sorts. There was discussion yesterday about sugars. I really personally prefer to talk about glucose, because sugar sounds like table sugar, and if it's agave nectar, it doesn't matter. We're talking about 6 carbon sugars, which is glucose, fructose, galactose, it's corn syrup, it's all the sugars you can think of, except for xylitol, which is a 5 carbon sugar. Tastes like sugar, looks like sugar, does all that sugar does. A few people get a bit of diarrhea from it, but mostly you can use it exactly like glucose sugar. Stevia, it tastes sweet. It's just a little pinch. It's something entirely different. Xylitol is actually converted in a pentose pathway in the body in and out of ribose, which you need for RNA and DNA, and it's metabolized well enough, but it doesn't make glucose. In the cells, glucose in the non-oxygen anaerobic part of the cell breaks down halfway. It breaks down from 6 carbon to 2 3-carbon units. In that pathway is an enzyme, PHI, that I mentioned, Cancer cells have failed mitochondria, so that they're desperate for energy, and they'll try and get it by increasing this Embden-Meyerhof pathway, so your PHI levels will go up, which is why we test for that. There was a compound researched and discovered in the 1930s odd called autocrine motility factor, AMF. And it was known to be associated with a lot of the harmful effects that cancer cells produce or do. And then it was discovered that AMF is exactly the same as PHI. Not only does it indicate that your cellular chemistry is anaerobic and therefore typical of cancer cells, PHI also inhibits apoptosis, it stimulates angiogenesis, it does a lot of the things that encourages cancer. Autocrine motility means the cell is self-generating its own mobility and its own activity, and it's going out of control. The next step through the cell is in the mitochondria, where arguably 95% of glucose energy is created. If that's not working, then obviously you're short of energy. You get cancer, you get tired, yes? Because you're just not producing enough energy. Your fats are broken down to 2 carbon compounds that go into this Krebs cycle in the mitochondria. So if your mitochondria is not working, you can't get energy from the fats. But listen, nor can the cancer cells. They can only get energy from glucose going through the anaerobic part on the slide before this. This is why giving up glucose, and starches are all glucose, thousands of glucoses joined together, are so important in the diet. It is critical. The ketogenic diet is really helpful. Can I ask questions later? Because I want to get through, but I will be around. A lot of it's in books, but I'll be around anyway. Yes? I'll try and cut it 5 minutes, okay. Yes, sure. It's a big subject. It is a big subject. When the mitochondria fail, you get build-up of pyruvate, you build up of lactic acid. This is another thing I would like to see included in the test panel. At the moment, the only lab that does that isn't one of the 2 that I use for all the other tests, but Genova Diagnostics, as you heard Patricia say yesterday, does it. And that NutriVital test is brilliant for telling you what's going on in the mitochondria. And if the mitochondria is failing, you've got to do something about it. And a lot of the B vitamins, B1, B2, B3, B5, particularly, lipoic acid, all sorts of nutrients are needed for this whole cycle to work. And the disabled cellular functions like no apoptosis goes on, compromised intercellular communication, the removal of restrictions on the cell's multiplication. So you can see that from this very early chemical change that you can detect way before you've got cancer cells fully formed in a tumor, you've got cancer-relating activities going on, but you can detect. And you can say, hey, pull back, let's do something about this. If it's 93% lifestyle, as a Professor Biave in Milan University has quoted, then you've got 93% chance of changing the lifestyle, or a large part of it, and doing a lot to counterbalance the other part of it. When the mitochondrial changes, you get DNA mutations. Oncogenes, the one that stimulate cancer, are turned on. The suppressor genes that protect you from cancer are turned off. Apoptosis is inhibited. Secondary causes then turn the genes on and you get more cancer. This is really not meant to be about the causes of cancer. This is really the background and the reasons why the tests are valid. For those who really want it, there's this fantastic book. It does cost £86. I couldn't put it down, but then I'm a biochemist. It was heavy going, but it's there if you want to. If not, read my thesis. There's John Beard. I talked to him about him just now to you. It's worth looking at noting this historical timeline. In 1924, when Warburg said he knew the causes of cancer, he knew mitochondria existed in the cells, But the electron transport chain in the Krebs cycle, not until 1961 were they recognized as being in the mitochondria, which in a way is where we said, hey, Warburg's right after all. Listen to him and work with it. So we have then a preliminary first test panel. HCG, you measure two forms. It's a very complicated molecule to test for. It has an alpha and a beta chain, 2 bits. One bit is similar to luteinizing hormone, follicle stimulating hormone, thyroid stimulating hormone, but the beta chain bit is on its own. So we do at least, I think, 3 tests for it. One of them collects only the intact total pure HCB, both chains. One collects all the different bits, the cores, the fragments, and the like, and of course that's usually slightly higher than the HCG on its own. And then in urine, you get another form of HCG, and if it's there in the urine, it helps validate the other tests. The test is done on serum. It's got 14 days to get to America. If it flies, it could make it. But it means that you're not trying to get blood halfway around the world in 24 hours. PHI is on the serum. Lactic acid, I've mentioned. The lab in America, American Metabolics, also does cancer embryonic antigen. A story on that. It's generally thought of as indicating colon cancer. Well, it probably indicates cancer. And if it does, it's probably cancer of the colon. That's about as reliable as you can make it. I read in Lancet magazine some 10 or 20 years ago, following colon surgery, quote, we could test for CEA to see if it's coming back or not. But we wouldn't know where it was coming back. So we couldn't do anything. So let's wait until there's a fully formed tumor that we can find, and then we can attack it. Beggars belief. I don't think CEA is all that important. In my research for the thesis, it didn't show up as often as PHI, HCGs, and the other things we're looking at. But it's in the panel, doesn't add to the cost, and it gives some useful information. Telomerase is interesting. It's actually the test that's done in England. It's not part of the American panel. Cancer cells have to, normally, every time your cells multiply, you lose a telomere. Patricia mentioned that, I think, yesterday too. When you've run out of all the telomeres, snipped off all the little bits and protect your shoelace down to the bit, as she called it, you die. Those cells die. It's called the Hayflick limit. And in some way, cancer cells have to bypass this Hayflick limit. They develop and produce a lot more of telomerase, the enzyme that puts telomeres back so that the cells can go on multiplying indefinitely. If you find that telomerase levels have gone up, that's a further warning that you've got activity going on. Some people want to take telomerase to stop themselves growing older. Personally, I'd rather grow old gracefully, I hope gracefully, and not risk getting cancer. It's not worth it. A lot of people are taking HCG, you'll see in the literature too, for slimming. Now, I don't want something in my body that can do a lot of the things that help cancer cells to, I worry about that, but I leave that to you to think about. We talked about that. And that, I really got ahead of myself. There's some of the consequences of raised PHI. I think I mentioned it before we had the slides. Stimulates progression, inhibits apoptosis, increases angiogenesis, increases metastases, increases... There's such a solid science behind all of this stuff. My degrees are all in chemistry and biochemistry, apart from the naturopathic one. There is so much there, and you think, and there's medical doctors writing and researchers writing, and then there's this huge brick wall, and there's oncologists. Oh, yes, cut, burn, poison. Thank you. And it's like they never speak, but of course they can't. And there are colleagues, I can name medical colleagues who've come so close to this wall and would love to be here, and they're getting letters saying, desist or you lose your medical license. So you've got to, the more you can talk about this to the more people, I've got, there's some cards and leaflets, just pass them around. It might save lives. This is what I really want to do. Useful in monitoring use in lactic acid. Lactic acid, yes, that's the one I want. Not only comes about, I didn't explain that, did I? I'm sorry it's a bit jumpy, but I had to talk without the slides. When the mitochondria don't work, the glucose, 6-carbon, goes to this 3-carbon compound and is a bottleneck, traffic jam, no entry, the traffic lights are red. So it produces lactic acid. Lactic acid is then in the liver converted back into glucose and it can go through again. But you only get this tiny bit of energy. And what I didn't say, sorry, when I talked about glucose, cancer cells can't get energy from fat. Remember, the fat bits come into the mitochondria. So you can really starve the cancer cells by cutting out the glucose. This lactic acid, though, cancer cells have worked out a way of getting energy out of lactic acid. It contains nearly as much energy as glucose, 617 versus 660 something units of energy. Cancer cells thrive on the energy from lactic acid. That's not, this slide's a little bit more chemical than we need, certainly, but it demonstrates how lactic acid is used by cancer cells for energy. Then, of course, the lactic acid is actually also a problem in itself, not just an indicator of cancer. It increases the risk of tumors. It increases the risk of metastasis. Dr. Freider, a German doctor who was 80, about 82 or 3, about 4 or 5 years ago and died now, but I was lucky enough to go to a small talk weekend she was giving for half a dozen of us in Munich. Her conviction is that lactic acid is immensely dangerous and that it stimulates the whole mitotic process. I can't find anything about this in the literature. I may do one day, especially the L-lactic acid. It increases angioedemic, increases the migration of cancer cells into clusters, increases secretion of hyaluronic acid, which changes the connective tissue and does various other things, increases metastases. It's dangerous stuff. This isn't the lactic acid if you go running and get tired or you whip up the eggs until your muscles work. That's very quickly cleared. But this persistent lactic acid is extremely dangerous. Associated with low energy, increased cancer, and aggressive and poor survival. CEA, we've skipped over that. I've got about 5 or 6 minutes left to touch on the other tests. Telomerase I've spoken of. Now, this is a concept I think is really important. No test is perfect. One gynecologist said to me, the pap smear is about 58% accurate. And yet, what do we base on a pap smear? Mammograms, we've seen that they're not perfect. None of these tests are perfect. They're not 100%. The body's too complex for that. There's too many chances of small errors cropping in the laboratory or whatever, however hard you work to keep them at a minimal. Not all cancer cells have raised HCG. They don't all have raised PHI. This is why I think a test panel is critical. It's like the sieve. You make it finer and finer and finer, and you catch more and more of the debris. If you are going to initiate a corrective protocol, I choose my words carefully, in response to finding any errors in these tests, it must be by alternative, harmless, non-toxic methods. I'm totally opposed to somebody getting a high HCG and going and having surgery. There's a study in the literature of 6 women who had raised HCG, very, very high HCG. They were tested for any sign of pregnancy or immediate past pregnancy. There was no sign there. It was assumed they all had amazing cancer of the uterus or ovaries or cervix. If you ask doctors, they'll say, HCG is only raised in pregnancy cancer. It's only raised in cancer of the uterus or whatever. Baloney. They were all operated on or given chemotherapy. They all had, I think they all had hysterectomies. One at least became diabetic, one went into a coma, and several had several other side effects until it was discovered that the lab had a mouse antigen, I think it was, and that was giving the false results. Now, if that false positive had said them, go and improve your diet, fine. If it had said, cut out toxins, fine. De-stress, fine. Do enemas, do detox protocols, fine. So a false positive might worry you, but you've got a 50% chance of getting cancer in your lifetime. Anybody born today certainly has got a 50% chance. We're very close to that figure now, and different figures vary. So if you've got a false positive and put yourself right, you're probably preventing something in future if it was a false positive. Many false positives, so-called, that you get aren't actually false. It's just that because this test, as far as I know, this panel of tests, is the first earliest warning sign you can get, you're not going to get corroboration of it until it's become something that you can detect by more gross means, you know, finding a tumor, for instance. So false positives are maybe worrying, but not too bad. The person who's worrying might say so, but whatever. False negatives are critical, because if you miss it, you're way behind in starting a recovery plan. So doing all of the tests, being very fussy about it. I had one patient, very sad story. She had very high PHI and nothing else. Her health wasn't good. She was run down, Her doctor said, look, you're fine. A year later, I phoned her up, what's happening? Oh, well, I said, well, we'll do the test again. PHI had shot up further. So then she took it a bit more seriously, but said, well, the doctor says it's not a problem. My friends say it's not a problem. You know, they'd know if it was whatever. 6 months later, she told me to take an hour to eat her meal. I said, go to your doctor and get a scan of your stomach. Because if it's taking an hour to get the food down, there's something down there. She came back with antacids and painkillers. I said, look, and she wasn't a very pushy woman. I said, go back, or I will get very cross with you. And I can get very cross. And get a scan. And she got it, and she had a big tumor in her stomach. And from then on, all we could do was anything that I could give her to help her general health was liquids. You know, you can't take pancreatic enzyme capsules when you've got blockages. And she didn't survive. You know, it was too late. So don't be put off. If people say this doesn't work, ask them how they know. Always ask for evidence of what's going on. But don't initiate and don't panic. You know, you could be picking up something so small, you've got plenty of chances of making a swift reversal of it. Protein 53, it's a really important protein, and it does get mutated. It's commonly mutated in cancer. And when it's mutated, P53 itself can't do its proper job. It builds up in the nucleus of the cells, and the P53 doesn't do the mutated P53 doesn't do the P53 job. It was discovered not all that long ago. It regulates the way the cells function. It's activated by any damage. It's a guardian of the threshold, guardian of the cell, I think it's called. If it sees any damage genetically in the cell, it tries to repair that. It interferes with the reproduction of the G1 phase of cellular reproduction, and it's forgiving. It says, okay, cell, correct yourself, and it sends out compounds that will help to repair the cell. But if the cell can't repair itself, it says, okay, cell, you had your chance, and it triggers apoptosis, and calls into play assistance from P21, and the cell dies. You need that. If that's not down, if that's low, you're in danger. If you've got cancer and it's low, it's not even trying to defend you. If it's high, it's out there fighting hard. It's being produced in greater quantity because it knows there's a problem, and you've probably got cancer process being active. So you need to know how to interpret these results, but it's there, it can be done. So what we said is, and I'll wrap up and then there can be some questions, that cancer is not a tumor. Cancer is a process. The process starts at the cellular level. It can start 10 or 15 years before you can get a diagnosis of cancer. As such, if you can detect that, you can put recoveries into place. I've got 5 minutes, apparently. I've itemized the first test panel for you, and I've itemized the second test panel for you. I've had somebody who had just one error in the first test panel. I said, look, it's probably not bad. I said, well, let's do the second one. And we found a lot of things going on. It was a sort of trigger. There are the laboratories, and I'm now open for questions. Yes, you had one. Thank you.
Excuse me?
I'll repeat questions if you like.
Yeah. Oh. No, I can shout.
Shout to me and I'll...
You mentioned that you can cut off the fuel supply to cancer like glucose.
Yes. You can, they can get some energy from a phosphorylation, substrate level phosphorylation of glutamine, yes. Well, just have enough protein, but don't go overboard on the protein. It's a sort of value judgment that. But the biggest way you can do it by any manner of means is to cut the glucose out. Other questions? Yes. Lactic acid is a small organic acid. Lactic dehydrogenase is the enzyme that catalyzes the conversion of pyruvate to lactate in an energy-dependent step in a non-reversible reaction. And because the cells can't convert lactate back to glucose, it has to go to the liver, and there it's made back into glucose, then it recycles. It's an inefficient way for cancer cells to get energy because it actually takes more energy to convert it back into glucose than they get out of it.
Would a high lactate dehydrogenase test in a conventional, that they do conventionally, does that correlate with having a high lactic acid, or is it different?
Keep in mind you're speaking to a chemist here, so I'm going to be very accurate in this.
Okay.
It might, but I haven't seen research on that.
Okay.
But it could be, off the top of my head, it could be that you are busy converting pyruvate to lactic. But I would do the test for lactic acid.
Okay, right.
Okay. Yes, green at the back.
I'm just curious, the Gerson diet has a lot of sugar in it. And
yes.
How does that correlate with?
Well, I think, you know, the Gerson diet started at a time when we didn't have all the capsules full of phytonutrients. The best way you could get in the 1950s and 60s, all these trace phytonutrients in, was to have a lot of fruits and vegetables. I think we now know, and I know I was in Mexico at the true Gerson clinic and the offspring from it, and his daughter's not willing to move forward and cut the fruit down. I think it should be. Budwig, Dr. Budwig, who proposed the combination of protein and flaxseed oil, that many, you know, her diet has fruit and grains in it. But that was 1950s too. It's gone. We obviously didn't know about where the Krebs cycle was working then and the dangers of all the glucoses.
Okay. Thank you.
Yes.
You've just mentioned the Budwig diet. There's Dr. Kusmin in Switzerland who uses the Budwig breakfast. And she had been treating cancers for 40 years until she died in 1993. Now, you're saying it's something that goes back to the 50s, but this diet has been used. I use it with my patients with great
yes.
reward.
Firstly, anybody who, I've got 1 minute, anybody who goes on the Budwig diet from a bad diet is on a better diet. Secondly, you can make it even better. I do think the protein flaxseed oil combination is very important. It doesn't have to be yogurt or cottage cheese for the people who don't want milk. You can use rice protein, whey protein. Question in the red shirt at the back. Sorry to be short. I'm allowed an extra 5 minutes, I'm told by the boss at the front.
Hi there.
Thanks, Fiona.
Following
having
Where are you?
having
Yes.
these tests carried out, I'm assuming the results would come back in a form that you could understand.
Absolutely.
How would I, having got those results, how would I interpret that and know
Okay.
what to do to
If
follow that
I
up?
is a patient, you need to go to a practitioner. If I is a practitioner that you're talking about, then the practitioner will need to learn to interpret it. Now, the labs do not like patients phoning in and asking. Particularly the one in Dorset doesn't, in Bournemouth doesn't. The one in America is more helpful, but they will say go to your practitioner. And you need practitioners to do the referrals. But it can be easily organized. I don't mind if Fiona wants to organize a group of practitioners. I can go through some of this in a lunch break or as a workshop or something. I don't know. I mean, I'm here. I'll do what I can. But you've got the websites. Yes. You can go online there. You can find out more. Dr. Galkina, this is interesting. Dr. Galkina, who runs that, is Russian, so and she talks fast and she pronounces all these technical terms, so it's a challenge. But she worked in Russia, in the medical system, in hospitals, doing research on all this, because this is what they do when they think about cancer in Russia. Way beyond what we do ever hear about cancer. Does that answer that?
Well, it sort of does, but a practitioner is...
I've been in practice since the early 1970s. And I was told yesterday by the man across the room, my arteries are 42 years old. So I quite like that. But anyway, I've been in general practice that long. I've been teaching biochemistry and nutrition in Australia at 2 or 3 different net practices. And I was in general practice until the turn of the century, you can say, when I completely focused in this field. Mainly because I wanted a challenge, and then, of course, it spread. I always thought in Australia, where I was practicing at the time, before this part, that you shouldn't take on cancer as a, helping people slot, unless you had really studied it absolutely in depth, because you don't know what you don't know. And it's only now that, well, not only now, but it's in these last 10 plus years that I and practitioners who really want to do this, we need to work up with it. There's a point for some sort of postgraduate seminar or something. Fiona's nodding, so keep your fingers crossed. Next question. Yes. Here in the front.
You mentioned the lactic acid that you were talking about wasn't the one that you got post-exercise.
Short bursts of lactic acid from exercise will go to the liver and get converted back into glucose, go to the cells, and they're fine. Dr. Freider talks of D-lactic acid, right-handed lactic acid, is what's normally produced. Dr. Freider talks about L-lactic acid, levorotatory lactic acid, being the one that's produced by cancer cells. I haven't seen any of this in writing. And she said that that was the one that really stimulated mitosis. What I do know from what I have researched is that it's not the occasional build-up. It's a chronic, long-term high of lactic acid, and unfortunately the writers haven't specified D or L lactic acid. But exercise isn't a problem. White shirt at the back. Oh, is that 1 minute? Or are you wanting a question?
Question.
Oh, sorry. Yes?
You mentioned a laboratory in Bournemouth.
Yeah, that's the Galkina laboratory, this one.
Fantastic. Okay, thank you.
But, if you're a practitioner and you want the kit, she'll send them out. I would talk with me before you do that, if you like, and I can sort of ease the way in. Question? Yes. Right at the front here. Good exercise. Keep you healthy.
Thank you. For those of us without a biochemical background, which of your books would be most helpful for starters?
What I'm writing is the Cancer Quartet. Vital Signs for Cancer Prevention is all about the signs that lead you up to getting it. But they're also all the things you should do once you've got it to try and reverse the protocol.
And that's called again?
Vital, it's a blue book at the end there. I've got a lot more at the hotel, but there's some there. And I need help bringing them up. Some strong man with a pull the trolley back. That's for cancer prevention and the very beginning of getting your lifestyle right for cancer concerns. It involves things like Beard and Volberg and the Budwig program, and the sort of foundation for where you build your anti-cancer or your recovery protocol. I may make this thesis the next one, but in fact what I'm halfway through writing is the third one, which is how you deal with the answers to every bad result in the second panel, the MMP2s and Baxes and all of those things. I mean, I would start with them both. I have to stop. Sorry.